Cardiovascular Module Part 2. Congenital heart disease. Heart failure and sudden death are the major causes of death among individuals with congenital heart disease. Due to the complexity of these problems, the Cardiovascular Advisory Panel guidelines for the medical examination of commercial motor drivers recommend that the driver has regular, ongoing follow-up by a cardiologist knowledgeable in adult congenital heart disease. The driver with congenital heart disease must meet the qualification standards. As a medical examiner, your decision to certify should be based on anatomic diagnosis, severity of the congenital defect, results of treatment, present fitness status, risk of sudden death or incapacitation. The FMCSA curriculum for medical examiners specifically discusses Epstein anomaly as it is one of the more common congenital heart disorders. Epstein anomaly is a congenital downward displacement of the tricuspid valve. The natural history of the patient with Epstein anomaly depends on its severity. Adults with a mild form of Epstein anomaly can remain asymptomatic throughout their lives. The diagnosis is made by echocardiography. With moderate tricuspid valve deformity and dysfunction, individuals usually develop symptoms during late adolescence or early adult life. Over 50% of individuals with Epstein anomaly have an intraatrial shunt. 20% have one or more accessory conduction pathways. You can certify the driver with Epstein anomaly if the driver is asymptomatic, has a mild tricuspid anomaly, has mild cardiac enlargement, has mild right ventricular dysfunction. Annual cardiovascular reevaluation should include echocardiography and evaluation by a cardiologist knowledgeable in adult congenital heart disease and who understands the functions and demands of commercial driving. Recommend not to certify if the driver has symptoms of dyspnea, palpitations, or paradoxical embolism, more than a mild anomaly, an intracardiac lesion such as an atrial septal defect, a shunt, a symptomatic arrhythmia, an accessory conduction pathway. Certification is possible after surgical intervention, assuming the driver has none of the disqualifying features listed. The maximum certification period is 1 year. Heart transplantation. Although the number of heart transplant recipients is relatively small, some recipients may wish to be commercial motor vehicle drivers. The major medical concerns for certification of a commercial driver heart recipient are transplant rejection and post-transplant atherosclerosis. The waiting period to drive is a minimum 1 year post-transplant. The maximum certification period is 6 months. Recommend to certify if the driver is asymptomatic, tolerates medications, has clearance from a cardiovascular specialist, has no signs of transplant rejection, meets all other qualification requirements. Monitoring the driver with a heart transplant should include reevaluation and recertification every 6 months by a cardiovascular specialist who is an expert in the fields of cardiology and transplant medicine, understands the functions and demands of commercial driving, evaluates the possibility of atherosclerosis, the status of the transplant, and the general health of the driver. Hypertrophic cardiomyopathy is a complex disease characterized by marked morphologic, genetic, and prognostic heterogeneity. Some individuals experience a benign and stable clinical course, while in others the disease is characterized by progressive symptoms. For some individuals, sudden death is the first definitive manifestation of the disease. Restrictive cardiomyopathy. The Mayo Clinic performed a study on idiopathic restrictive cardiomyopathy between 1979 and 1996. The clinical profile and outcome of idiopathic restrictive cardiomyopathy report indicated a 5-year survival rate of only 64%, compared with an expected survival rate of 85%. Do not certify if the driver has a diagnosis of hypertrophic cardiomyopathy or a diagnosis of restrictive cardiomyopathy. Aneurysms, peripheral vascular disease, and venous diseases. Abdominal aortic aneurysm. The majority of abdominal aortic aneurysms occur in the 6th and 7th decades of life and occur more frequently in males than in females by a 3-to-1 ratio. The majority of abdominal aortic aneurysms are asymptomatic. An abdominal aortic aneurysm can be associated with other cardiovascular disease. The overall detection rate of abdominal aortic aneurysms on examination is 31%. Detection during a physical examination depends on aneurysm size and is affected by obesity. Clinical examination identifies approximately 90% of aneurysms greater than 6 centimeters. Auscultation of an abdominal bruit may indicate the presence of an aneurysm. Rupture is the most serious complication of an abdominal aortic aneurysm and can be life-threatening. The risk of rupture increases as the aneurysm increases in size. An abdominal aortic aneurysm less than 4 centimeters rarely ruptures. Smaller than 5 centimeters has a 1% to 3% per year rate of rupture. 5 to 6 centimeters has a 5% to 10% per year rate of rupture. Greater than 7 centimeters has approximately a 20% per year rate of rupture. Recommend to certify if the driver with an abdominal aortic aneurysm has an aneurysm that is less than 4 centimeters and the driver is asymptomatic. If the abdominal aortic aneurysm is greater than 4 centimeters but less than 5 centimeters and the driver is asymptomatic and has clearance from a cardiovascular specialist. Following surgical repair of an aneurysm, the waiting period to drive is a minimum of 3 months. The maximum certification period is 1 year. Do not certify if the driver has symptoms regardless of the size of the abdominal aortic aneurysm, a recommendation for surgical repair regardless of aneurysm size, or if the aneurysm is greater than 4 centimeters but less than 5 centimeters and the driver does not have medical clearance from a cardiovascular specialist, if the aneurysm is greater than or equal to 5 centimeters, if the aneurysm has increased more than 0.5 centimeters during a 6-month period, regardless of its size. Ultrasound has almost 100% sensitivity and specificity for detecting abdominal aortic aneurysm and is recommended to monitor change in size. The driver should have an annual medical examination. Thoracic aortic aneurysm. While relatively rare, thoracic aneurysms are increasing in frequency. The size of the aorta is considered the major factor in determining risk for dissection or rupture of a thoracic aneurysm. Previous FMCSA guidance was that a driver with an asymptomatic thoracic aneurysm could be certified if the aneurysm is less than 3.5 centimeters and has clearance from a cardiovascular specialist. The FMCSA now recognizes that thoracic aneurysms less than 5 centimeters and are asymptomatic are not likely to rupture. The waiting period for certification is a minimum of 3 months post-surgical repair. The maximum certification period is 1 year. Aneurysms can develop in visceral and peripheral arteries and venous vessels. Rupture of any of these aneurysms can lead to gradual or sudden incapacitation and death. Much of the information on aortic aneurysms is applicable to aneurysms in other arteries. The waiting period for certification is a minimum 3 months following surgical repair of an aneurysm. Recommend to certify if the driver has clearance from a cardiovascular specialist. The maximum certification period is 1 year. Do not certify if the driver has a recommendation for surgical repair of an aneurysm but has yet to have surgery. With improved surgical outcomes and without contraindication for surgery, aneurysms can be electively repaired to prevent rupture. The decision by the treating provider not to surgically repair an aneurysm does not mean that the driver can be certified to drive safely. However, a recommendation to surgically repair an aneurysm disqualifies the driver until the aneurysm has been repaired and a satisfactory recovery period has passed. Acute deep vein thrombosis. The commercial driver is at an increased risk for developing acute deep vein thrombosis due to long hours of sitting as part of the profession. DVT can be the source of pulmonary emboli that can cause gradual or sudden incapacitation or death. Adequate treatment with anticoagulants decreases the risk of recurrent thrombosis by approximately 80%. The maximum certification period is 1 year. When DVT treatment includes anticoagulant therapy, the driver should meet monitoring guidelines which will be discussed later in this module. Chronic thrombotic venous disease of the legs increases the risk of pulmonary emboli. However, there is insufficient research to confirm the level of risk. As a medical examiner, you must evaluate on a case-by-case basis to determine if the driver meets cardiovascular requirements. Recommend to certify if the driver has no symptoms. The maximum certification period is 2 years for such patients. Intermittent claudication. This is the primary symptom of obstructive vascular disease of the lower extremities. It develops in 7 to 9% of persons with peripheral vascular disease and is a strong predictor for cardiovascular disease, increasing the 10-year cardiovascular disease mortality by 10 to 15-fold. In cases of severe arterial insufficiency, necrosis, neuropathy, and atrophy may occur. Recommend to certify if the driver, following surgery, has relief of symptoms and no other disqualifying cardiovascular disease. The maximum certification period is 1 year. The waiting period for certification is a minimum of 3 months following surgical repair. Recommend not to certify if the driver has pain at rest. Although superficial phlebitis is a benign and self-limited disease, DVT is often a coexisting condition and needs to be excluded during the course of examination. The driver with superficial phlebitis may be certified for 2 years. Varicose veins with the associated symptoms and complications affect more than 20 million people in the United States. Complications include chronic venous insufficiency, leg ulcerations, and recurrent DVT. The presence of varicose veins does not medically disqualify the driver. Deep vein thrombosis can be one of the sources of pulmonary emboli. Pulmonary embolism can cause gradual or sudden incapacitation and significant morbidity and mortality. The waiting period is a minimum 3 months without further pulmonary embolism. Certify if the driver has appropriate long-term treatment and no other disqualifying cardiovascular disease. The maximum certification period is 1 year. Do not certify if the driver has symptoms. When treatment of pulmonary embolism includes anticoagulant therapy, the driver must meet anticoagulant monitoring guidelines, which, as noted, will be discussed later in this module. Valvular heart disease. The mandated FMCSA curriculum for the NRCME exam training course includes detailed certification criteria for many valvular disorders. Therefore, we will be reviewing each valvular disease, but note that the NRCME exam rarely, if ever, asks any questions on specific valve disease qualifying criteria. Murmurs are a common sign of valvular heart conditions. However, the presence of a murmur may be associated with other cardiovascular conditions. As a medical examiner, you must distinguish between functional murmurs and pathological murmurs that are medically disqualifying. The intensity of murmurs is classified on a scale of 1 to 6, from the least pronounced murmur to the loudest. Classification is rated as follows. Grade 1. You must strain to hear a murmur. Grade 2. You can hear a faint murmur without straining. Grade 3. You can easily hear a moderately loud murmur. Grade 4. You can easily hear a moderately loud murmur that has a thrill. Grade 5. You can hear the murmur when only part of the stethoscope is in contact with the skin. Grade 6. You can hear the murmur with the stethoscope close to the skin. It does not have to be in contact with the skin to detect the murmur. Murmurs that are systolic and grade 1 or 2 are usually benign if the driver has no signs or symptoms of heart disease. Mid-systolic murmurs are usually benign if the driver has no signs or symptoms of heart disease. Additional evaluation is recommended when murmurs are systolic, grade 1 or 2, and the driver has signs or symptoms of heart disease, systolic and grade 3 or higher, holosystolic or late systolic, diastolic or continuous. Exceptions are common with higher grade murmurs. When in doubt about the severity of a heart murmur, you should obtain additional evaluation. Aortic regurgitation. Aortic regurgitation is usually a chronic condition characterized by a prolonged asymptomatic phase and gradual left ventricular dilatation. Other conditions such as infective endocarditis and aortic dissection can result in acute severe aortic regurgitation. The recommendations are for chronic aortic regurgitation. Recommendation parameters for aortic regurgitation include the severity of the diagnosis, left ventricular size, and the presence of signs or symptoms. Mild or moderate aortic regurgitation occurs in the presence of normal left ventricular systolic function and little or no left ventricular enlargement. Severe aortic regurgitation occurs with a normal LV systolic function but significant LV dilatation. The maximum certification period is 1 year for mild to moderate aortic regurgitation. Certify if the driver has mild aortic regurgitation that is asymptomatic, moderate aortic regurgitation with normal LV function, no or mild LV enlargement, and the driver is asymptomatic. Do not certify if the driver has symptoms or has moderate aortic regurgitation with abnormal LV function or more than mild LV enlargement. Echocardiography is repeated every 2 to 3 years for the driver certified with mild or moderate aortic regurgitation. Certify if the driver has no symptoms, normal LV function, LV dilatation, but the LV end diastolic dimension is less than 60 millimeters, and the LV end systolic dimension is less than 50 millimeters. The maximum certification period for severe aortic regurgitation is 6 months if not surgically repaired. The waiting period is a minimum 3 months following aortic valve repair for severe aortic regurgitation. The driver who has had surgical repair for severe aortic regurgitation may be certified for 1 year. Do not certify if the driver with severe aortic regurgitation is symptomatic, is unable to achieve a workload greater than 6 METs on Bruce protocol, has reduced left ventricular ejection fraction less than 50%, has LV dilatation with an LV end diastolic dimension greater than 70 millimeters, and LV end systolic dimension greater than 55 millimeters. Aortic stenosis. The most common cause of aortic stenosis in adults is a degenerative process associated with many of the risk factors underlying atherosclerosis. The onset of angina, syncope, or heart failure after a long latent period is clinically significant. After the onset of symptoms, the average survival is 2 to 3 years, and there is a high risk for sudden death. Atrial fibrillation is also a significant problem for individuals with aortic stenosis. Certify if the driver has mild aortic stenosis that is asymptomatic, moderate aortic stenosis that is asymptomatic and the driver has no disqualifying findings or conditions, severe aortic stenosis that has been surgically repaired and meets all aortic valve repair surgical guidelines. The maximum certification period is 1 year. The waiting period is a minimum of 3 months if post-surgery. Do not certify if the driver has moderate aortic stenosis with one or more of the following: angina, heart failure, atrial fibrillation, left ventricular dysfunction with an ejection fraction of less than 50%, thromboembolism, or the driver has severe aortic stenosis regardless of symptoms or left ventricular function. Following certification, echocardiography is repeated every 5 years if mild aortic stenosis and every 1 to 2 years if moderate aortic stenosis. FMCSA guidelines recommend not certifying the commercial motor vehicle driver with severe aortic stenosis regardless of symptoms or left ventricular function. The waiting period following aortic valve repair is 3 months, and the maximum certification period is 1 year. Do not certify if the driver following aortic valve repair has thromboembolic complications. Recommendation parameters for mitral regurgitation include the severity of the diagnosis and the presence of symptoms. The development of symptoms, especially dyspnea, fatigue, orthopnea, or paroxysmal nocturnal dyspnea, is a marker of a poor prognosis, including an inability to perform driver tasks and increased risk for sudden cardiac death. Certify if the driver has mild or moderate mitral regurgitation if asymptomatic, normal left ventricular size and function, and normal pulmonary artery pressure. Certify if the driver has severe mitral regurgitation that is asymptomatic. Certify if the driver has surgical mitral valve repair from mitral regurgitation, is asymptomatic, and has clearance from a cardiovascular specialist. The maximum certification period is 1 year. The minimum waiting period is 3 months following mitral valve repair. Do not certify if the driver has mild, moderate, or severe mitral regurgitation and has symptoms, less than 6 METs on a Bruce protocol, ruptured chordae or flail leaflet, atrial fibrillation, left ventricular dysfunction, thromboembolism, pulmonary hypertension. The driver with moderate mitral regurgitation should have an annual echocardiogram. The driver with severe mitral regurgitation should have an exercise tolerance test and echocardiography every 6 to 12 months. Recommendations for mitral stenosis are based on valve area size and the presence of signs or symptoms. Ask about episodes of angina or syncope, fatigue, and the ability to perform tasks that require exertion. Certify if the driver has mild mitral stenosis that is asymptomatic, moderate mitral stenosis that is asymptomatic, severe mitral stenosis, and clearance from a cardiovascular specialist. The maximum certification period is 1 year. Do not certify if the driver has severe mitral stenosis until successfully treated. Regarding ongoing monitoring, the frequency of cardiovascular specialist evaluation depends on the development and severity of symptoms. However, it should be performed at least annually, including a chest X-ray, echocardiogram, and two-dimensional echocardiography with Doppler or other mitral stenosis severity assessment. Procedures for the treatment of mitral stenosis include percutaneous balloon mitral valvotomy and surgical commissurotomy. Symptomatic improvement occurs almost immediately, but after 9 years, recurrent symptoms are present in approximately 60% of individuals. The minimum waiting period is 4 weeks if post-percutaneous balloon mitral valvotomy. The minimum is 3 months if post-surgical commissurotomy. The maximum certification period is 1 year. For either procedure, certify if the driver is asymptomatic, has clearance from a cardiovascular specialist, has experienced no thromboembolic complications, has experienced no pulmonary hypertension. Do not certify if the driver has thromboembolic complications or pulmonary hypertension. The driver should have an annual cardiology evaluation, which should include an echocardiogram. Mitral valve prolapse. The natural history of mitral valve prolapse is extremely variable and depends on the extent of myxomatous degeneration, the degree of mitral regurgitation, and association with other conditions. Mitral valve prolapse is usually a benign condition. In some cases, mitral regurgitation may be progressive, resulting in left ventricular and left atrial enlargement, atrial fibrillation, and congestive heart failure. The maximum certification period is 1 year. Do not certify if the driver has symptoms or reduced effort tolerance due to mitral valve prolapse or mitral regurgitation, ruptured chordae or flail leaflet, systemic emboli, atrial fibrillation, syncope or documented ventricular tachycardia, severe mitral regurgitation, or left ventricular dysfunction. An exercise tolerance test may be helpful in the patient with mitral valve prolapse to assess symptoms. Drivers who have definite mitral regurgitation, even if mild, or markedly thickened leaflets should have an echocardiogram at least annually and clearance from a cardiovascular specialist who understands the functions and demands of commercial driving. Prosthetic valves. The clinical course is heavily influenced by factors other than valve-related complications, for example, left ventricular dysfunction, congestive heart failure, progression of disease in other valves, coronary disease, or pulmonary hypertension. Prosthetic valves can be mechanical or biological. There are a wide range of reported complications depending on the variable methods of reporting, the make and model of the prosthesis, the site of implantation, comorbidities, and underlying left ventricular function, among other causes. The waiting period is a minimum of 3 months post-prosthetic valve replacement. Certify if the driver is asymptomatic and has clearance from a cardiovascular specialist. The maximum certification period is 1 year. Do not certify if the driver has persistent symptoms, left ventricular dysfunction defined as an ejection fraction of less than 40%, thromboembolic complications post-procedure, atrial fibrillation, pulmonary hypertension, inadequate anticoagulation based on INR checks at least monthly. Monitoring involves the following. If treatment includes anticoagulant therapy, the driver should meet INR monitoring guidelines. Echocardiography is indicated in the event of concerns about prosthetic valve dysfunction, perivalvular leaks, new murmurs, or left ventricular function. Exercise tolerance testing may be required to assess work capacity. Pulmonary valve stenosis is usually a well-tolerated cardiac lesion, normally exhibiting a gradual progression. Gradual or sudden incapacitation may, however, occur in certain circumstances. Recommend to certify if the driver has mild or moderate pulmonary valve stenosis, or pulmonary valve stenosis corrected by surgical valvotomy or balloon valvuloplasty. The maximum certification period is 1 year. The waiting period is a minimum 1 month if post-balloon valvuloplasty and a minimum of 3 months if post-surgical valvotomy. Do not certify if the driver has symptoms of dyspnea, palpitations, or syncope, a pulmonary valve peak gradient greater than 50 in the presence of a normal cardiac output, a right ventricular pressure greater than 50% systemic pressure, more than right ventricular hypertrophy noted by echocardiography, more than mild right ventricular dysfunction noted by echocardiography, more than moderate pulmonary valve regurgitation noted by echocardiography, a main pulmonary artery diameter greater than 5 centimeters. For a driver on anticoagulant therapy, the examiner must document the underlying condition requiring anticoagulation, control of the underlying condition, and, if on warfarin, the frequency with which the driver has the INR checked. For the driver taking warfarin, the driver should bring results of INR monitoring to the certification examination, or the examiner may request a copy of the most recent report from the primary care physician. The examiner should review the need for the driver to discuss with the treating physician any new medications or supplements the driver plans to take. Many medications can increase or decrease the anticoagulant effect of warfarin. The medical examiner has a responsibility to inform and educate the driver about use, effects, and side effects of medications that can interfere with safe driving. Recommend to certify if the driver taking warfarin is stabilized on medication for at least 1 month, provides a copy of the INR results at the examination, has at least monthly INR monitoring. The maximum certification period is 1 year. Recommend not to certify if the INR is not being monitored, if the INR is not therapeutic, if the underlying disease is disqualifying. The FMCSA has provided no guidance at this time regarding the use of newer anticoagulant agents and CMV certification. The overall risks of bleeding are similar to vitamin K antagonists, however the risks for intracranial bleeding are less with the direct oral anticoagulants. They require no monitoring and there are less food and drug interactions. The medical examiner will need to assess the driver who's on one of the newer anticoagulant agents based on the underlying condition and supporting documentation from the treating physician. Can an interstate commercial motor vehicle driver who has had an acute MI be qualified to drive? Yes, provided the acute MI was at least 2 months prior to the date of the CMV driver physical examination, the driver meets all other recommended cardiac qualification criteria, and the driver meets all other standards for interstate CMV drivers. The driver provides the medical examiner with a copy of his medical records, including a cardiologist report indicating a diagnosis of congestive heart failure and that the driver's ejection fraction is 35%. Can the driver be certified? No. The ejection fraction needs to be at least 40% for the driver to be certified. What criteria must be met in order for the FMCSA medical examiner to qualify a driver with a known diagnosis of congestive heart failure? The driver must be asymptomatic, have no ventricular arrhythmias, have an LV ejection fraction of at least 40%, be under the care of a cardiologist or appropriate medical professional. A driver has an abdominal aortic aneurysm. The medical examiner obtains a copy of an abdominal sonogram indicating that the aneurysm is 5.3 centimeters in diameter. According to current recommendations, should the medical examiner certify this individual? No. For a driver to be certified, the abdominal aortic aneurysm should be less than 5 centimeters. A driver gives the examiner a letter from his cardiovascular surgeon indicating that he had surgical repair of a 9 centimeter abdominal aortic aneurysm 4 months previously, and the driver is now cleared to resume all duties. According to current recommendations, can the examiner certify the driver? Yes, for up to 1 year. According to current recommendations, drivers with a successfully repaired abdominal aortic aneurysm can return to driving 3 months postoperatively if their surgeon clears them to do so, but they must be rechecked every year. Can you certify a driver with the following history? Coronary artery bypass graft surgery 4 months ago. Echo at 3 months showed an LV ejection fraction of 55%. The driver was cleared by his cardiologist and he has no chest pain. Medically qualified. According to current recommendations, the driver who has had a CABG may be qualified at 3 months post-procedure if asymptomatic. The LV ejection fraction is greater than or equal to 40%, and meets all other recommendations. Qualify with an annual recertification. Clinical scenario. These clinical scenarios are provided by the FMCSA as part of its NRCME examiner curriculum. Mr. Jason Feldstein is a 62-year-old male who presents for a recertification examination. His health history is notable for a cabbage 6 weeks ago. He takes aspirin daily. Health history comments. The presence of unstable angina led to cabbage 6 weeks ago. The driver states that he feels, quote, 10 years younger since surgery. Included in the cardiologist report dated 3.5 weeks post-cabbage surgery is clearance for driving, quote, okay to drive. Mr. Feldstein denies any post-surgery episodes of angina. Mr. Feldstein also tolerates daily low-dose aspirin with no side effects that interfere with driving ability. His blood pressure is 112/66, his pulse is 64 and regular. His LV ejection fraction is not included with medical records that Mr. Feldstein brought to examination. Physical examination comments. On auscultation, there is an S4 gallop heard best at the sternum. He has a median sternotomy scar consistent with recent surgery. The rest of the physical examination was unremarkable. What is the certification decision in this scenario? The medical examiner used current cardiovascular guidance that include having the driver complete a minimum 3-month waiting period to allow for sufficient time for the sternum to heal. The medical records provided by the driver also needed to include a post-surgical LV ejection fraction measurement that was at least 40% to meet certification guidelines. Mr. Benjamin Gray is a 45-year-old man who presents for a recertification examination. In the health history section of the medical examination report form, he responded yes to a history of a heart attack. He takes an aspirin daily. Health history comments. He is currently seeing a cardiologist for a single episode of chest pain that occurred 2 weeks ago while roofing his home. The chest pain lasted half an hour and gradually resolved without treatment. The pain was located primarily in the left pectoral area, not radiating, and aggravated by movement of the left arm. It, quote, felt like a Charlie horse, with mild residual soreness present for about 24 hours. Mr. Gray consulted with his primary care physician, who referred him to a cardiologist. The cardiologist reports a normal EKG. He scheduled lab work and a stress test and echocardiogram in 2 weeks. He prescribed no medications and no activity restrictions. Mr. Gray has had no recurrence of the chest pain. He continues to run 2 to 3 miles 3 times each week without symptoms. He has no previous history of cardiovascular disease. Mr. Gray is a non-smoker and has no hyperlipidemia history. His father had an MI at age 69. On exam, the blood pressure was 112/70 and his pulse was 84 and regular. The physical examination was unremarkable. What is the certification decision in this scenario? The medical examiner certified the driver for 3 months to follow up on lab and stress test results. The cardiovascular standard requires the driver, quote, have no current clinical diagnosis of myocardial infarction, angina pectoris, coronary insufficiency, thrombosis, or any other cardiovascular disease of a variety known to be accompanied by syncope, dyspnea, collapse, or congestive cardiac failure. Neither the primary care provider or cardiologist examinations of Mr. Gray confirmed a diagnosis of coronary heart disease. It is not the role of the medical examiner to diagnose and treat the driver. However, the medical examiner decides whether the nature and severity of the condition is such that the driver is at a high risk for sudden incapacitation. The physical examination was unremarkable, and Mr. Gray had resumed normal activities prior to examination. Neither the primary care provider report nor the cardiologist report indicate the driver is at an increased risk for a cardiac event. The underlying cause of chest pain appears to be from the chest wall musculature. However, the driver is scheduled for additional lab work and stress testing. The medical examiner shortened the interval to ensure the laboratory work and stress test results are considered before making a final decision on the certification period. Discuss what the medical examiner determination is likely to be if the test results are normal. What date denotes the start of the certification period? If the medical examiner follows up on the test results and does not perform a complete examination of the driver, with no current clinical diagnosis of cardiovascular disease, he may be certified for up to 2 years from the date of the original examination. If the medical examiner performs another complete physical examination in addition to reviewing the test results, With no current clinical diagnosis of cardiovascular disease, the driver may be certified for up to 2 years from the day of the repeat examination. This completes Module 4, Cardiovascular.